Our next speaker is Professor Lisa Keay. Lisa is the head of the School of Optometry and Vision Science at UNSW and an honorary professorial fellow at the George Institute for Global Health. She's a public health researcher with expertise in epidemiology, health promotion, health systems research and injury prevention. She was trained as an optometrist but has a PhD and a Master of Public Health. Her research activities focus on patient-centred healthcare, impact of vision loss and prevention of injury in older people with a vision impairment. Lisa's short presentation is an update from the Ophthalmology Network, Cataract Surgery Policy Changes. Thanks, Lisa.
Thanks very much. I'd also like to thank the network for accommodating this late-breaking update, which I was very enthusiastic to share. You can see in small print there on the slide, I'm joined by my colleague Kerrie Martin, who's the Ophthalmology Network Manager at the Agency for Clinical Innovation at New South Wales Ministry of Health. And Dr. Michael Hennessy, unfortunately, couldn't come today because he had clinical commitments. And for those of us who puzzle over the translation from research into policy, I would like to, call out Michael here because he was a real champion for this change. He's the co-chair of the Ophthalmology Network. I'd also, it's lovely to follow on from Stephen's talk because we saw about vision as a risk factor, and I know I'm not going to do a show of hands, but there's very few people here who spend all their time working in vision and eye health. So I think it's a real opportunity for further engagement, and following on from Francis's talk this morning, if we treat this falls prevention like tobacco, if every sector gets involved and everyone's working together to get real benefits, we can make some differences. So just to orient you to what happens when you get cataract, most of us as we age have the lens inside our eye change and it gets a little bit yellower, a little bit less transparent. So the picture here is a lovely one to share, what your normal vision would be like. So to walk down these stairs, thankfully there's a bit of contrast on the edge of these stairs, but when you have cataract, and we've also got a bit of glaucoma thrown in there, you lose that ability to see edges clearly, and that's the contrast sensitivity which Stephen was speaking about in his risk factor presentation. So we know that lots of people have cataract. If you live long enough, you're going to have clinically significant cataract, basically, and it's a prevalence of about almost 3% in people 50 years and older, and so that's 240,000 odd Australians, and that's people with enough cataract so they're getting beyond what we would need to keep a driver's licence. So this is actually having a big impact. Fortunately, we can do curative surgery for cataract, and that's a little picture on the bottom there shows an intraocular lens, and really you can go from one day of having vision that's impaired from cataract to having really nice clear vision if that's the only problem you have. And we do about 250,000 surgeries in Australia. About 70% are done privately, so that's where you're accessing services and paying substantially out of pocket to get your surgery done. You can get it done quite relatively easily, but about a third of Australians rely on public hospital waiting lists, and it's actually 80% of Aboriginal and Torres Strait Islanders. So there's creeping up to be some inequity, and we've followed on nicely by showing how this is a risk factor for falls, so we obviously need to be helping these people to see as well as they can, so they can navigate, they can detect obstacles, and also so they can exercise and get the other benefits, because we know that people with poor vision don't get out and about and lose their independence. So what happens in Australia? This is a graph from the Atlas of healthcare variation. So they only pick up on issues that have got some substantial inequities. And we know that through the different colours across this graph, without you needing to read the numbers there, that's the rate of surgery. So how many people per population are getting their surgeries done? There's a 4 times variation. So I put in the picture of Sydney because we can see in Sydney, the north of Sydney has got nice dark blue colours. They're getting quite a lot of surgeries done. The southwest of Sydney is not getting their surgeries done. So, and this is places where people are more likely to be relying on public hospital waiting lists. It's one issue. There's other issues around not getting access to cataract surgery, but wait lists are definitely a big problem. We did some research, and this is the exciting bit of seeing some research we've done being cited and used to inform policy change. This was actually a cohort study. The only randomised trial was back in the late, around 2000 in the UK. But what we showed in our following people through their cataract surgery journey in public hospital waiting lists, that we really didn't get that benefit for lower rates of falls until they've had both surgeries done. And then we've done some economic modelling to complement that, and Jessie's presenting that this afternoon in the rapid fire session, so you can see some of that business case for government, that it's really worth investing in a highly successful, cost-effective surgery. So I'm going to hand over to Kerrie now to tell us about what has actually changed. Over to you.
Thanks, Lisa. So yeah, really, really exciting news, and acknowledgement to Michael Hennessy for advocating for about 17 years for this change, and all the clinical evidence and research work that Lisa and Peter McCluskey and Andrew White and teams have done to help make this policy change. So in March they announced to the chief execs of LHDs and specialty health networks that from July next year, second eye cataract recommended category will be reduced down to 90 days. So at the moment it's 1 year. So I'm sure there's a lot of people who know someone in their family or friends who've had cataracts, and the big difference it makes in their vision, and having one done and then waiting, and then the increase in falls. The Australian Commission on Safety and Quality in Healthcare put out their clinical care standard for cataracts in 2021. They have a whole statement section on second eye surgery, that they say the options for a patient with bilateral cataract are discussed when the decision about the first eye surgery is being made. So from now till July next year, there's been a few procedure codes introduced, so for left eye and right eye, and the government are now funding places that have second eye wait lists that are beyond the 90 days, so they're really trying to get those wait lists down, and because of post-COVID and all of that as well. So by July next year, there'll be lots more comms going out through the Ministry of Health and through the Agency Clinical Innovation, through the Ophthalmology Network, and also the Surgical Services Task Force, and that's why we're here today. So if anyone has any questions, come and see me in the lunch break. I'm happy to chat with you. Thanks.
Thank you so much to Lisa and Kerrie. This is great news and great to see such good and important research being translated to policy change.